Hello, good evening, everyone. And sorry for this, but we are here, of course. So don't worry, we are ready to educate you and we are ready to simply provide some answers. Definitely, our special guest, Dr. Elias Tsakos, is definitely ready to answer some of your questions. So, hello, Dr. Tsakos. Welcome back to my IVF Answers. How have you been?
Hi,
Busy
good
as
evening.
always.
Yeah, how are you?
All good. Glad that we are here. And this is definitely an interesting topic that we are going to discuss today, endometrial rejuvenation. And so I'm sure you have plenty of steps to tell us about, and of course, how it works and how anyone can gain from it as well, right? To have more success. So as always, just please remember that we will start with Dr. Tsakos' presentation. Let me remind for those who haven't been on our webinars, Dr. Tsakos is the Medical Director of Embryoclinic in Thessaloniki in Greece, and he's been with us for many years now, and he's an excellent expert, and I can only encourage you to type all of your questions in the chat, and Dr. Tsakos definitely answer them for you. If you had a chance to be on one of our webinars, you know he's very thorough, so don't hesitate. This is definitely your chance to get some useful tips. All right, that will be it from me for now. I think we can start with the presentation. Tsakos, ready?
Sure. Hi, Caroline. Hi,
you.
everyone. I'm very happy to be here with you tonight. It's 9 p.m. in Greece. It's, I don't know what the time in your countries is, but it's probably in Central Europe, 8 p.m., so that's pretty late. 7 p.m. in London, and I don't know if someone is listening from outside Europe. And welcome, everyone. Thank you for attending. I will spend the next 20 minutes trying to convey my updated knowledge on endometrial PRP. It is an innovation. It is a new technique. Although it's been going on for about 10 years in medicine overall, in fertility, as far as fertility application is concerned, it's fairly new. Until recently, I mean, I've been studying this technique and the research. I've been talking to various colleagues all over the world, in Europe, in the US, some of the pioneers of this technique. I've been reading the articles for many years. I've been under a lot of pressure for about 10 years to apply this technique, and I haven't done it until recently, until the beginning of this year. And the reason was that personally, my team and I, we have a research and development department here at Embryoclinic. When it comes to innovation, there's a thorough process of assessment of the available data, the available science, and that usually includes our own studies. Sometimes we produce our own scientific data and meta-analysis of the available data before we embark on an innovation. A perfect example of that has been robotic surgery that we've started employing about 5 years ago, and we have produced some nice research evidence on the value of robotic surgery, for example, on various types of disease and pathology like fibroids, like endometrial cancer, and so forth. So we followed this technique, this approach on PRP, and until the end of last year, we hadn't been convinced. We weren't convinced that there may be some clinical value. Of course, data kept coming in, and then suddenly, towards the end of 2023, there were some very interesting papers, some very interesting data that have convinced us that perhaps there is evidence. We extensively studied the data, the evidence, and we thought that it was time to press the button. So we pressed the start button in the beginning of 2024. So for many of you who might be listening in and who may have been perhaps rejected for PRP treatment at Embryoclinic in the last few years until recently, you may see now a change of heart. And I will try to explain why this has happened. So I will try to be very brief and hopefully give you some data on that. So introduction, the content of my today's talk is introduction of endometrial PRP, What is it? How is it produced? The initials stand for platelet-rich plasma. So plasma is coming from blood, and so the whole technique involves the extraction of very high density and high quantity per microliter, high density concentration of platelets within the specimen that we produce from patients' own blood and patients' own plasma. So how does it work? What's the scientific evidence, and what's the future prospect? So more or less, this is what it looks like. I mean, this is the part of the centrifuge, if you like, of patients' own blood that contains high density of platelets. So what is it? It's an autologous product. So it's a product that comes from patient's own body fluids, blood. It's derived from peripheral blood. So basically, we just draw blood from the patient themselves. We prepare it via centrifugation. This is an extra demanding technique. It took us many months, and most of my staff at Embryoclinic, including myself, we gave quite a few mLs, quite a few quantity of our own blood in order to reach to our own scientific evidence, scientific data of how much blood do we need, what kind of protocol do we need to employ in order to achieve that concentration of platelets in the sample that we use for treatment. It took us many months. I'm very grateful to the lab personnel of Embryoclinic, in particular Konstantina Papa, and of course Gilda Hasidis and Leah Kasapi, and our main supervisor, Dave Gibbon. So there was a lot of time consumed in order to identify and find the best possible combination of centrifugation times, speeds, and how many centrifugations we would need, and of course to perform all those techniques under aseptic techniques, make sure that the samples are not infected, because blood is the perfect environment for microbes and bugs to grow. So, we've done extensive quality control in order to be happy to launch the service. Thankfully, there's no extra medications or substances needed. The simple delivery of the product via infusion into the endometrial cavity. We haven't had any incidents of allergies or adverse effects, and in the literature there's very, very, very small possibility of that happening. And of course, this is a technique that has been used for many years for medical specialties. I must admit that I have bugged a lot of my colleagues, a lot of my orthopedic friends all over the world, especially those specialized in injuries, in athletic injuries, involved with teams. Actually, I personally spoke with, the local teams here in Thessaloniki. I spoke to the doctors of the local teams, the doctors and orthopedic surgeons of the national teams treating high-level athletes, and in order to get some feedback. So it has been used for injuries, for knee injuries, for hip injuries, and so forth in orthopedics. It has been used for degenerative disease in orthopedics. It has been used from plastic surgeons for rejuvenation of various parts of the skin and various healing processes by cardiothoracic and abdominal surgeons and so forth. And it has been used by the new specialty of aesthetic gynecology that tries to improve the aesthetic and functional gynecology, trying to improve anomalies in the external genitalia of women. And of course, it has been used by fertility specialists for many years in order to improve the endometrial function, not just the appearance on the scan, but also the function in terms of recepting and receptivity of the embryo, and also has been used for ovarian rejuvenation. I mean, I'm not sure I like the rejuvenation term, to be honest. I will use it, but I don't 100% agree with it. I don't know. I'm not sure about it. I would call it ovarian treatment or endometrial treatment in an attempt to improve fertility. I already have a question now here on the Q&A section, whether I'm going to touch upon the ovarian rejuvenation. No is the answer, but hopefully there's another webinar coming, so I will dedicate that to ovaries. At the moment, we will speak on endometrium. Now, how is it done? It's a simple and quick process. It's not that simple and it's not that quick. I don't know about other people. There are some kits, there are some machines. I'm not going to mention names that portray that they can achieve that concentration within 20 minutes, 10 minutes. We tried many of them. We didn't have the exact outcomes that we wanted because, and this is one of my messages, bottom line in this treatment, and this is something that perhaps is making most of the research not so valuable, is that very few people actually do quality control on this sample that they're injecting. And what is quality control? Is measuring the concentration, the density of platelets in this sample. And also quality control is culturing this sample to ensure and confirm that it's microbe-free, that the microbiology culture is negative. I think it's imperative that we do it simply because in terms of concentration for fertility treatment, we need a very, very high concentration of platelets in this sample in the region of more than 800,000 platelets per microliter. So the only way to ensure that this is what we've been doing is by measuring that. It took us many trials, many errors, and many attempts in order to get to that level. And again, in order to be able to assess the outcome of your infusion into the uterus, you need to be aware of what's the concentration you have injected in order to assess prospectively the outcome. And of course, in order to decide whether one infusion is enough or perhaps whether you need to do more in order to achieve the optimum outcome. This is an area that hasn't really seriously been touched upon in many studies. And of course, this was one of the reasons of my hesitation of many years before we started employing this technique. It's definitely non-interventional. It's like an endometrial transfer, or like an IUI, if you like it. Now here we say it's performed 5 days prior to embryo transfer. This is one protocol, but of course there's more protocols. And please remember that this may be employed outside the context of IVF. So you may have a totally fertile couple with either miscarriages or thin endometrium who do not need IVF. So it's not just associated with the context of IVF. And I will explain later other indications for endometrial PRP. It is painless. I mean, I think we're exaggerating if we say completely. It's not completely painless, but it's fairly painless, and there's no anesthesia required. So as you can see, I'm very critical of my own slides sometimes. And it's performed with a thin catheter similar to embryo transfer and IUI. It is, in my opinion, important that this is performed in a aseptic, in a theater environment, or in an IVF clinic environment, or in a hospital environment, to ensure a few factors like aseptic technique, ensure nice culture within the laminar flow of the lab, and ensure that of course the personnel is there to support any adverse reactions, very rare, like vasovagal faint attacks, or sometimes we have stress disorders associated. So we need to be in a supporting environment. I wouldn't perform that in my outpatients with a secretary sitting outside and no personnel being able to support my patients in case of an adverse reaction, which is very rare, but it can happen. And the total duration of the injection is 8 to 15 minutes. So depending on how smooth we are, how cooperative the patients are and all that. So how is the PRP produced? We take the blood, take patient's blood, the whole blood, we centrifuge it. Now this is a little bit like the Coca-Cola secret. I mean, most people wouldn't share the combination of centrifusion in terms of what type of machinery we use, how many revs per minute, how many cycles of centrifusion, and for how long. My colleagues and friends are more than welcome to ask me, and I would be more than welcome to share my experience, my limited experience until now. And although I didn't have a similar experience when I tried to ask some of the experts in the world, they wouldn't be very happy to share the data, but I am. So if you're a doctor, a biologist, a technician, PRP, a specialist, I would be more than happy to share our data, because I think only through this best knowledge and best practice share we can get more evidence, we can become better for our patients. So we use the centrifuge in order to separate the platelets, and this is what we have after the centrifusion, and this is where the plasma lies. And actually this is one of the common disagreements, I would say, because I had plenty of discussions with people who claim that they do that. Some people will take the whole of this, some people, which includes the platelet poor plasma. Even some of the machines, expensive machines that are available in the market, they would use all of it. But if you use all of it, you don't have the concentration that you need. And the concentration we need, it has got metrics, and the metrics is minimum 800 platelets per microliter, and we need 2 to 3 microliters, mLs infusion. So we need to take this fella here, not the whole thing. Which is our practice. We take 30 to 40 mLs. Many papers, I mean, there's a disagreement here. Don't be scared. This is not huge number. It's fairly reasonable number. I mean, if somebody's having a full hormonal, biochemical, vitamin and genetic test, we probably need that amount of blood. So this is common practice when we do one-step clinic for IVF. And we measure all those parameters in the blood. So we need more than many papers refer to as standard, which is 20 mLs of blood. So in our practice, we use a little bit more. The blood undergoes initially a long centrifusion. We use specialized tubes in order to achieve that. And then we separate the plasma, we separate the centrifuge into plasma and concentrated rich red blood cells, and then we take out the platelet-rich plasma. So on average, we use 2 mLs of PRP fluid, and some of this, a small proportion of this, we sacrifice for our quality control every single time, because we need to know what we're injecting. And on average, we have 4 to 5 times the platelet concentration on the eventual fluid. So how does it work? What's the theory behind it? There's a beautiful theory behind it, I must admit, fascinating. And we call it the power of the humble platelet. The godfather of this term is Dr. Manos Xidias, who is my research fellow, one of the brightest and best research fellows I've ever met in my life, not just in my clinic. So we're very happy to have him here. So he is behind this name, the power of humble platelet. So what are the activities? The activity is through proteins, antimicrobial proteins, growth factor proteins, and anti-inflammatory cytokines. And we know that the ability of those humble platelet concentrates lies on cell proliferation, tissue healing, neoangiogenesis, so the ability of the own body to produce new veins, new vessels, and immune modulation, so a lot of activity. So cell proliferation is through the growth factors. Immune modulation is via the cytokines and interleukins. I'm not going to go into much detail because preparing this for a scientific talk to my colleagues and associates next month. And the reduction of scarring, and that's why there is clear indication for use of PRP in cases of Asherman syndrome, in cases of previous surgeries on the uterus, and in cases of obvious scarring on the uterus that may be associated with adverse fertility issues. And there's even proposals for use of this technique for prevention of adhesion formation. So, if someone, for example, has a repeat uterine surgery, maybe for scars, for Ashermans, for polyps, for miscarriages, and so forth, we may even use it for prevention. And what's the evidence? I'm not going to go through all the available papers. There's a plethora of published papers. To be honest, this is the paper that turned the tide in my scientific decision to proceed with that. Of course, we're collecting data of our own patients as well, and we're hoping that eventually we will publish our own results. So this is an amazing paper. It was only published last year, and in the BMC, which is a very, very good quality journal. So this is a meta-analysis on the effect of other studies. They've included some good quality studies that provided all the evidence that personally my team and I we needed in order to proceed in the clinical application. So this is your average, and this is a properly designed meta-analysis. Average infertility patient, I don't particularly like the term. They probably mean the standard infertility patient. So someone with standards, so with no particular other characteristics apart from infertility. So they found 81% higher implantation rate, 84% better clinical pregnancy rate, reduction on miscarriage rate. Here you can see each one of those studies individually, and here you can see the overall outcome of the study, and 75% higher live birth rate. Now, what is fascinating is that the achievement of better endometrial thickness was only on average 1 millimeter for many of you and many of us. This is perhaps negligible, but it seems to be important. And, for many of us, looking at endometrium at 6.5, which is pretty low, 70.5 endometrium is very near to normal. So perhaps in those patients, it matters. And higher positive pregnancy beta HCG, no difference in multiple pregnancies as one would expect, and no difference in ectopic pregnancy. Now, it's fascinating that in the subgroup of patients with implantation failures, then the positive effect was found to be even better. And perhaps these are the patients that we may need to look at more carefully before applying this technique. And of course, in patients with thin endometrium. Thin endometrium usually indicates adhesions, Ashermans, and in those cases, it seems to have a much better value. That's why in my practice initially, I only include patients with indications, so high-risk patients, either with thin endometrium or with multiple miscarriages. So what are the future prospects of IVF? And a lot of prospects of infusion PRP, although there's few pilot studies. Initially, most people are actually focused on patients with recurrent implantation failure and thin endometrium. We can even inject PRP via direct vision with a hysteroscope, which may, in theory, improve its effect. And there are some scientific reports presented recently that this may be of benefit. Now, beyond the endometrium, we have the ovarian PRP. I'm not going to keep you in agony. All I have to say is that at the moment, the evidence perhaps is not as good as it is for endometrium, but I'm hoping that more evidence will emerge. And my team and I are collecting the evidence in order to be able to present an opinion, if you like, of its validity. Ovarian PRP is reserved for patients who are one step or half step before giving up on their own eggs, either because of poor response, or because of previous surgery on the ovaries, or because of early menopause, early climacteric and menopause, and so forth. And of course, it has been proposed not just for fertility factors, but also for prolonging the ovarian function and prolonging the menopause. So hang in there, and hopefully we should have some more data to present in the next few months. Thank you very much. This is my take-home message, that PRP is autologous blood products that has been safely and successfully applied in many medical fields in the last decade or so, including fertility. It induces cell proliferation and improves vascularity and blood flow in the endometrium. It's a simple, fairly painless, inexpensive and quick procedure, and the reproductive outcomes have been fairly impressive to date, particularly in recurrent implantation failure and thin endometrium patients. This is the literature for those of you who want to look into that. This is my team, and I'm very happy and proud of them. I would like to thank them, on many counts. And one of them is that they back me up when I'm presenting and preparing all those presentations. And for my team, I would like to say special thanks to Dr. Manos Xidias, who helps me prepare those amazing presentations. Thank you for your work, Manos, and of course the lab team who have been seriously involved with this technique. Thank you very much. I'm full of ears to listen to questions. Please be prepared that I may not be able to answer all of them, but I will try to be as honest and as scientific as I can. Thank you.
Brilliant. Thank you so much. As always, interesting. As always, great presentation indeed. So thank you for this. And you are very right. Lots of questions are already here. Remember that we have around 30 minutes for those questions. So don't hesitate. Type them all in. We will try our best to answer. As Dr. Tsakos said, maybe not all of them, but we will definitely have a look at them as much as possible. And let me go to the first question here. So can this treatment can this treatment help in adenomyosis or endometriosis cases?
I don't know is the answer, the clear answer. Depends on what we're treating. Adenomyosis, I can't see any mechanisms by which they could be beneficial, unless adenomyosis has caused scarring of the endometrium, and unless it has caused miscarriages that were treated surgically that may have caused scarring in the endometrium and so forth. So direct effect on the adenomyosis in the wall of the uterus, I can't see any mechanism that may be helpful, because mainly it's directed on the endometrium. Now, endometriosis again depends on the location. I presume you're referring to ovarian endometriosis, like endometrioma, and endometrioma, as we all know, endometriomas have an adverse effect on the ovarian reserve, and they may lead to someone having had surgery on the ovaries. In theory, that would be referring to ovarian PRP, which is the subject of my next webinar. So I'm going to stay on the fence a little bit here.
That makes sense, of course. Thank you so much indeed for answering the first question. Okay, so thank you for your presentation. I appreciate it. This is this is the information about the PRP, ovarian PRP. We will skip it as Dr. Tsakos mentioned. We will have a webinar on PRP, ovarian PRP. So stay tuned, and of course, as I mentioned, you can have a look at our previous webinars on this particular topic as well. Okay, next question: can growth factors be dangerous and induce some unintended cell signaling?
Yeah, sure. I mean, this is always a concern. This is always something that I think most people cannot answer. Depends on the crosstalk between the different pathways. Depends on the expression of those growth factors. I mean, of course, we don't want them to be overexpressed. Very difficult to answer all that. It has to do with genetics, with epigenetics, with other effects. I don't know is the clear answer, but even if it does on the endometrium, I think it's very, very unlikely that it may cause abnormal growth or malignancy and so forth. We definitely need to be on the lookout, but at the moment, there's no particular evidence of adverse effects of growth factors contained in the PRP fluid, and we haven't really had any serious reports from orthopedic surgeons who have been using that for more than a decade.
Okay, brilliant. Thank you so much indeed for this again.
On the other hand, chronic inflammation may be associated with pathological changes. So, maybe there's more scope into growth factors fighting chronic inflammation and improving healing that may prevent from pathological changes than not. But of course, with any innovation, we need to be on the lookout. We need to monitor, we need to record, we need to inform, we need to counsel, we need to consent our patients. So by all means, this is a very, very clear and it's a very valid concern that we should be having.
Mm-hmm. Okay, thank you for adding that. Let me show you the next question here. Some details as well. So for Asherman syndrome, should the treatment be done at the same time as when as adelolysis? I'm not sure is being done, or would it be done after IUD or balloon catheter has been removed?
Yeah. Maybe is the answer. Yeah, maybe. Actually, I usually discuss that option. I mean, especially when it comes with international patients and patients from flying far away. So yeah, we can do it during hysteroscopy and adhesiolysis. That has a couple of advantages. One is that it's two procedures with one go or one anesthetic. If we give anesthesia or if we give local, it's 2 in 1. We kill 2 birds with 1 stone. Secondly is that we may be able to direct PRP infusion in the areas of excessive scarring, if there is one, in the hope that that would work a little bit more. So yes, it can be done.
Mm-hmm. Okay, I hope that answers your question. I believe so. So would PRP still be beneficial even when it is done in the menstrual cycle before the transfer? Yeah,
absolutely. Well, I mean, it depends on why we're doing it. It depends on the assessment and it depends on the indication. So, for example, if we have an Asherman syndrome, no, I wouldn't do it before the embryo transfer because invariably with Asherman syndrome, I would need perhaps a second look hysteroscopy as well after the treatment. So for Asherman syndrome, no. For someone with extremely thin endometrium, perhaps 4 millimeters or 3 millimeters, again, I wouldn't do it in the embryo transfer cycle because I would have no time to assess the effect. In the embryo transfer cycle, I would probably do it for someone with recurrent miscarriages or with 1 miscarriage. and thin endometrium, someone with thin endometrium secondary to perhaps endometritis or endometrial surgery or multiple endometrial surgeries, who have a borderline endometrium, perhaps a 7 or 8 millimeters. So in that case, I would probably discuss. I mean, I'm very cautious. I mean, I don't think it's one size fits all, and I don't think it's for everyone. And I'm very, very careful to who I advise endometrial PRP, given that the evidence is coming through now. So someone with 7, 8 millimeters with a thin endometrium and perhaps with 1 or 2 failures or 1 or 2 episodes of endometrial surgery, yeah, then I would do it 4 to 5 days prior to the embryo transfer.
Yeah, brilliant. Thank you so much indeed for yet another answer. How long does it last? That's the next question.
Depends is the answer, and we don't know. We don't clearly know. We don't have enough evidence. Depends on the patient. I don't know is the answer. But what I have seen in my few months experience now is that if you do it for patients with extremely thin endometrium, it may take a couple of months to see that millimeter or 2 millimeters. And may I mention here that it's not just the size and the thickness of endometrium. There's perhaps another 12 at least parameters that we look at, like the shape, the vascularity, the trilaminar appearance, and so forth. The Doppler studies that we do on that. 3D seems to be not superior at the moment, but it's definitely helpful. So it's not just the size. And 1 millimeter can play between myself within 10 minutes difference on the same patient. So there's a lot of parameters we look. We don't really know how much it's lasting for. At the moment, we have some extreme cases that we have used it, some desperate cases of nearly absolute factor, endometrial factor, because if someone has a totally hopeless endometrium, 3 to 4 millimeters associated with Asherman's type 4 and half a dozen hysteroscopies, you don't really have much option than trying perhaps this technique. Otherwise, you would have to resort to either surrogacy or uterine transplantation. And there's a lot of such cases. So we've used it on some desperate cases. And, one of them, someone who had such a thin endometrium, such a thin myometrium, that when we did hycosi, the fluid went through the uterus into the endometrial cavity, into the abdominal cavity, and we thought that it was almost transparent. It was a little sliver, like little layer of endometrium, and then it was nothing. So on that patient, we saw thickening of the myometrium to 5 millimeters, 6 millimeters, when it was 2 millimeters before. So, we tried on desperate cases. So there seems to be some movement there. There seems to be some effect, but how long does it last for? And whether that could be associated with a good outcome at the end, we don't really know. We're here to find out. We're here to monitor the data. We're here to discuss with our patients, discuss with our colleagues. We're here to protect our patients, keep an eye on the endometrium. As I said before, I do not think it's one size fits all. I don't think it's a miracle technique that will, cure the Asherman syndrome forever. No, it's not going to happen. All we're doing here is trying to improve the chances of the individual patient, especially the ones with damaged endometrium or with multiple failures, to have a better chance.
Okay. Thank you so much. Now I will go to the question we just received, okay, because the other ones are more about PRP, ovarian PRP, but let's have a look. So you always do only one time, or do you always do it one time or sometimes more than once? Always 5 days prior to transfer, sometimes after the follicular aspiration? Why don't do it earlier in the cycle? This is the question.
Yeah, sure. I mean, there's no agreement on what we should be doing. I mean, I believe that perhaps in the next couple of years, we may be having conferences on PRP, like we have conferences on robotic surgery or hysteroscopic surgery and so forth. At the ESHRE this year, and I'm very, very happy for that, there's a pre-congress workshop that I'm happily participating. That's on the Sunday before the official opening of the conference. And I'm hoping that I should be able to interact with some wonderful people in that workshop in order to perhaps agree on some guidelines and agree on some best practice. So watch the space. Hopefully my ovarian PRP webinar will be after that. And hopefully I will have some more data from that workshop to share with you. So depends is the answer. I mean, depends. It's empirical. This is a technique that's under, a lot of criticism. Actually, I was watching a panel from very respectful scientists and clinicians only a couple of days ago, and most of them are skeptical. But on the other hand, we can't turn a blind eye on a technique that has been used for 10 years, more than that, a technique that has got publications, a technique that has got theoretical advantages, a technique that has got scientific evidence, published data, meta-analysis, no matter how, if for some people those original studies are not perhaps of perfect quality. There is evidence out there, at least for endometrial PRP, that with caution, with strict criteria of safety and quality control, that we need more data, and that the data seems to be promising.
Okay, sounds good as well. I'm waiting for some more questions. There is one I think we can still answer, okay? I want to ask if you had any patient trying ovarian PRP, trying to increase the pregnancy chances, and if yes, was it a success or it had different results on different patients?
Yes, I had, but I don't think it's valuable to share. I mean, it's outside the scope of today's webinar. All I can say is that I can give 3 messages from my limited personal clinical experience, although my theoretical experience is about 10 years. First, number 1, if you have PRP, make sure it's performed under very strict conditions. So in a theater condition, in an OR, in an IVF clinic, a licensed IVF clinic condition, not in a doctor's office condition. Number 2, insist on quality control, because we were unpleasantly surprised when we did quality control on the samples, thankfully of our own blood, before we decided which technique to use. So we did quality control on very, very branded machines and machinery and equipment that and very expensive for that matter, that we used, and even CE marked, even FDA approved, that the concentrate of the platelets was very, very low, very small. 100,000, 200,000, that's not good enough. So make sure it's done in a licensed proper facility. Make sure that you have a report of the sample that was injected, so that you know what they've given you. And number 3, that you have very, very careful counseling and consent. So it's not a marketing thing. It's not something that we should be very liberally making available, in my opinion. We should be very cautious, and we should be, selecting patients who have clear indication that they need something extra from what we've been doing so far, which is giving estrogens, perhaps giving different modes of introduction of those estrogens, oral, transdermal, vaginal, and they haven't worked, that we have used some add-ons in order to deliver those estrogens in the endometrium, and that all of those have either produced neither very poor endometrium or multiple failures and miscarriages. So I would reserve endometrial PRP, despite the evidence that at the moment it may be beneficial for the average, for the standard fertility patient. I would personally reserve it for patients with clear indication of endometrial factor infertility.
Okay, brilliant. Thank you again for that. There is one more question, and let me just show you this, of course, if you can clarify. If you have more questions, please go ahead, type those in. We still have a few minutes, but of course, let's see. So are you familiar with that? Because I'm sorry, I don't know what that is, the stem cell therapy, the name is here. So is it similar to PRP?
Well, yes and no. I mean, basically it's not, because we're talking about different substances. You know, it's similar in terms of being autologous. It's from patient's own cells, and it is directed into the organ that needs to be treated. I'm not going to use the term rejuvenated. In my opinion, I think we have to agree on PRP first, which is the simplest of those treatments. We have to agree on perhaps some protocols, perhaps some indications, perhaps some outcomes. And then once this is secure, then scientifically secure, then with more evidence, then we perhaps may consider moving on to stem cell treatment and so forth. I feel that it's probably going to be a couple more years, if not more, before we proceed to that.
Okay, thank you.
You know, the fact that people are doing it doesn't mean, and have been doing it, it doesn't mean that it's scientifically sound and effective.
Still something that we need to wait for more evidence, right? So hopefully it's coming. Thank you so much. I don't see more questions, so we will be finishing for today. But thank you so much for joining, and thank you so much for being interactive and of course engaging today as well. Dr. Tsakos, it's been great to have you. Of course, as Dr. Tsakos already said, there will be an event in September. I checked. In September, we'll talk about PRP with Dr. Tsakos as well. So we will have more information, hopefully, after ASHRA as well. So thank you. And before we finish, any final thoughts, any final words you wish to add?
Thank you for being here. Thank you for looking. Thank you for doubting, and thank you for questioning. You are the ones who make us better, the ones who make us come out of the comfort zone. My default answer to any innovation is maybe, or I hope so. It's definitely not yes, and it's definitely not no. And I think that should be our ethos. I mean, we should be examining. If we can't personally, we should trust our teams, and we should trust our colleagues. We should examining, exploring, researching new possibilities, new innovations, because the aim is always the same one: to grow every day, to become better every day, and to offer every day better outcomes to our patients.
Perfect summary, indeed. Thank you so much for that. Before we finish, one more thing I want to add. We will be back, of course, next Tuesday. We will talk about what factors will affect your IVF success. So we've invited 3 different doctors. Dr. Tsakos already had a chance to participate in this in the Ask Your Doctor event. So I'm glad that it's going well again. And of course, we have invited 3 other doctors. So if this is something you want to find out more, join us. The link is in the chat, but also you can just simply go to myivfinstance.com. You know that there are plenty more events coming up. Dr. Tsakos, looking forward to some events shortly with you. Have a lovely evening, and take care. See you here.
See you. Good
night. See you back here.
Thank you, everyone. Thank you.
As well. Thank you. Bye-bye.
Bye.